going to talk about guidelines and groups of pulmonary hypertension and management strategies. Thank you. I need that. All right, so I work in a multidisciplinary clinic, and that's how I infiltrated this program tonight. I work closely with a pulmonologist, actually 2 pulmonologists now, and a cardiologist, Dr. John Ryan is our cardiologist, Nate Hatton is our pulmonologist, and Emily Beck has just joined our practice. We started about 8 years ago as a half-a-day clinic supporting our scleroderma program, and we have blossomed and grown, and we have worked ourselves out of our quarters. We are accredited by the Pulmonary Hypertension Association, which is important because pulmonary hypertension is such a sort of complex, common but very uncommon problem at the same time. So there's been this push to get programs accredited. We felt it was important for us and it was important for our patients to start playing by the rules, playing by guidelines, making sure patients get treated in the best possible care. So we are a dual focus. We also work closely with Craig Salzman, who I know comes here in our CTEF program, and I'll talk about that a little bit later and show you some cases. I do speak for Actilian, that is my disclosure, and our objectives are just to talk about pH. Slow me down, or you want to slow me down, I'm happy to talk about these things more in depth. So I have lots of questions for you just to think about. Feel free to get up and move around. I know you've been sitting for a while too. Pulmonary hypertension, here's your first true or false. Pulmonary hypertension, or pH, is defined as a mean pulmonary artery pressure of 25 millimeters of mercury or more. Got your answer? It depends. So every 5 years, a world symposium gets together internationally about pulmonary hypertension. And in 2018, they decided to sort of come out with this new idea that the 25 millimeter mercury value was arbitrary. So we should probably actually base this on normal Cath values. The thought is that a normal value is probably about 14. 2 standard deviations would give us anything more than 20 should be considered abnormal in the world of pulmonary hypertension. So treatment recommendations are still very unclear from that 20 to 25 zone, but 20 is our new standard of where we're calling patients pulmonary hypertension patients. There's 5 groups of pH. Who knows that? All right. The way I explain this to our patients is we talk about 5 groups. Number 1 is not the most common, not the most important, but it's our way of putting people in boxes to know how to treat them. So the first group is a blood vessel problem. It's a lung problem. The blood vessels in the lungs get tight and pressures go up. It's usually associated with another disease. Group 2 is your territory. This is an inefficient heart problem. Patients don't have heart failure with preserved ejection fraction, or they don't really quite comprehend diastolic dysfunction, or several of the other reasons to have an efficient heart. But that's the way that we can wrap our head around that. Group 3 has to do with oxygen problems. Not all lung disease or pulmonary hypertension with lung disease actually has to have a lung disease. So who here has treated a patient with sleep apnea? If you haven't, you need to be asking. And then group 4 is blood clots. So chronic thromboembolic pH, and group 5 I call random and rare, and we're not going to spend any time on. When our patients go to the Pulmonary Hypertension Association website, this is what they'll see with patients with pH. We tend to talk about pulmonary arterial hypertension a lot, but in this slide, it represents 3% of all patients with pulmonary hypertension. So it's actually a tiny little subgroup. The challenge is most people will present with one of these symptoms, but they're very vague. I'm short of breath, and some say, oh, I'm lightheaded. Every now and again, we get somebody who goes snowboarding and they pass out and they end up in the hospital with us and we diagnose with pH. But the majority of the time, they're short of breath. Okay, so here's a hemodynamics case. I apologize, but this is hard to see. In this case, the patient has a mean PA pressure of 58, a wedge pressure of 20, but their PVR is 6.78. So where do they fit? This is the 6th symposium definitions of our hemodynamic definitions. So precapillary pulmonary hypertension, what we would consider PAH in most cases, is a mean PA greater than 20, a wedge is less than 15, and a PVR of 3. Well, his wedge is higher. Isolated postcapillary pulmonary hypertension, mean P is 20, wedge is more than 15, and then a PVR is less than 3. Well, his PVR is almost 7. So he falls in this combined pre- and postcapillary pH picture. We don't quite know what to do with those patients yet. The answer is not pulmonary vasodilator therapy. Maybe one day it will when we can figure out these phenotypes, but right now they still fall within clinical 2 and 5 groups. Why is this so important? Anybody with pulmonary hypertension, if left untreated, leads to right heart failure and death. So this is a single-centered cohort study that actually shows the mortality of patients grouped into different pH groups. And I know that's hard to see too, but these bottom lines are not PAH. PAH is actually up here. So what that tells us is that pulmonary hypertension is clinically important to everybody. There's been a greater push to identify PAH early, especially PAH, and get patients on therapies. We doing okay? Sorry to rush this. So let's dive into the workup. This is also from the guidelines or the proceedings. Patient has history of something that leads you to think they need an echo, they're short of breath, whatnot. How do we know where to go next? On the echo, we look at a TR jet. The average sort of where we start to really think about pulmonary hypertension is when we see an RVSP of 35, but we know that that's not the whole story, right? There's some error in that measurement. We start looking at ventricle sizes and atrial sizes, the right side versus the left side. Then we have to decide, is it high or intermediate probability based on maybe RVSP is really high or maybe RVSP is moderate, but now they have some right ventricle changes, maybe their right atrium is big. Well, we're going to decide who needs to get a referral where. And so we fast-track selected patients. Any idea who those selected patients are? Okay, here's my list. These patients are most likely to have pulmonary arterial hypertension. They have significant risk factors. So connective tissue disease patients, we're thinking about scleroderma and lupus. Patients who are seen in our programs get annual echoes, they get annual PFTs to help us try to screen for PAH. So we can catch it, we can treat it, we can help those patients. Congenital heart disease, we saw a lot of patients who have ASD closures, maybe as teenagers, that then go on to develop PAH, and we treat it. And I always have to bring drug and toxins up because we don't know about a lot of our meth use. In the last year, we instituted a screening protocol. We've had 3 patients who've told us, nope, never use meth to test positive the day we did screening studies. So that means they've used within the last week. And we asked everybody those questions. We started screening everybody. It doesn't necessarily change a lot other than, from a treatment perspective, and those patients need help. We're never going to make them better if they're continuing to use the one thing that's causing their disease. Okay? Fen-phen was the big diagnose in the 1990s, but also led to some PH. HIV, there's a small subset of HIV patients that will have PH, and then a family history. And we're talking about aunts, uncles, cousins, but the challenge here is a lot of aunts, uncles, and cousins also can have HFpEF. So clarifying what that means. If you really think somebody has familial PAH, we've got to get a genetic counselor, not just ordering those labs because those patients have several repercussions lifelong of knowing their genetic status if it's positive. And then portal hypertension. As we know, our nation is getting bigger in many ways. We're seeing more cirrhosis, particularly from obesity, and that can lead to portal hypertension and portal pulmonary hypertension, especially in liver transplant candidates. They cannot have a transplant if those pressures are high. They will die on the table. And then schistosomiasis is the worldwide leading cause of pulmonary hypertension. We don't typically see it in the developed nations, but our patients travel. Our patients are immigrants. We just transplanted a guy with schistosomiasis last year and pulmonary hypertension. We good? Sorry, okay, so let's say we haven't identified any of those risk factors. What do we do next? The next step is to start considering what profile does this patient have. DQ scan, rule out right-sided heart or left-sided heart disease, I guess. And then what's the probability of lung disease? If they don't have that, the recommendation is to refer to an expert care center, just because we're trying to figure these patients out. And this is this push to make sure we're getting more consistent patients. We're treating them correctly and not over-treating or under-treating. So the message and the takeaway here is it's always appropriate to refer to a referral center, whether it's starting therapy, whether it's end stage and they need advanced therapies, whether it's lung transplant time, treatment escalation, whatever. It is always appropriate to get to a referral center. We actually have 2 now in the state of Utah. The University of Utah, of course, is one of them. We were first. And then Sacramento, I think, is your next closest actual pulmonary hypertension accredited facility. This is our workup. And I encourage anybody who's working at pulmonary hypertension to have a very standardized approach to pH, because when we were accredited, we had to go through our charts, and in our heads, every patient had a VQ scan. Every patient had every single one of these things checked out. And we should have kept a log of how many actually didn't meet all of the criteria, but they do now. An echo, a VQ, pulmonary function tests, which we'll talk about, an overnight oximetry, probably a polysomnography just to make sure you're not missing sleep apnea, and then screening studies before getting to a heart cath. Now, that's not always the ideal thing. Some patients end up with a heart cath, and they come to us and they say, hey, I have pulmonary hypertension. We still go through all of these tests to try to figure out where is this pulmonary hypertension coming from, because pulmonary arterial hypertension is so rare. And we want to treat it correctly. So what's the purpose of the heart cath? Yes, we get a pressure estimate, but as we've alluded to before, pressures may not be the whole story. You can actually have a low PA pressure and very, very severe pulmonary hypertension. So we look at right atrial pressure, we look at cardiac index, and try to make a determination of how severe is this picture. Get a wedge pressure or an LVDP if you're lucky at end expiration when it comes to our wedge pressures. And I'll show you an example in just a second. Exclude congenital heart disease and vasoreactivity testing. You guys familiar with vasoreactivity testing? Yeah, perfect. So vasoreactivity testing is where we look to see if any of those pulmonary pressures can improve with some reversibility agents. Those agents are inhaled nitric oxide, adenosine, ibuprostanol, or inhaled iloprost. Those are the only ones that are indicated within our pH guidelines to test for vasoreactivity. Why this is so important, and it's only for idiopathic familial and our toxin-associated patients, because of scleroderma, it hasn't really panned out. So few of those patients are vasoreactive, but people who are vasoreactive do better long-term, and we can treat them with calcium channel blockers, which are pennies compared to the cost of these other drugs, as well as it's the right thing by the patient. Any questions, right? And then provocative testing. Do you guys do exercise? Do you do exercise caths or fluid bolsters in Cath? The whole purpose of provocative testing is try to uncover HFpEF, because HFpEF is, if you're a betting person, that's going to be the second somebody walks into your office with pulmonary hypertension, is that their pH is due to left heart disease simply in the first game. And of course, you have to look at the whole picture. But provocative testing is recommended as a 500 milliliter fluid bolus. And if that wedge goes to 18 or more, that's considered abnormal, and you can consider HFpEF uncovered. Okay. All right, next true or false question. Who group 1 pH is the only treatable type of pulmonary hypertension? All right, so we still treat and manage every type of pH. PAH and CTEP are the only 2 that have FDA-approved therapies, but we certainly don't leave our patients. Treatment algorithms. Are you guys interested in talking about the treatments of PAH therapies? We can also have this conversation later. So the way we decide what treatments to put a patient on actually has to do with a risk assessment. Low to intermediate risk patients start 2 therapies. The push in the PH community is you get those patients on therapy early and you be aggressive with it. When I started 8 years ago, it was we add 1 therapy in 3 to 6 months, evaluate and see if we need another 3 to 6 months, we reevaluate and see where we're at. It's now we're in that office having a conversation with the patient. We're starting 2 therapies at least. These are the 2 risk assessments that are widely used. The first is a REVEAL calculator. The second is the ERS ECS guideline. Really what this tells us is if a patient comes to the hospital, their cardiac index sucks, their right atrium is huge, and their functional class is in the toilet, they need to be on prostacyclins. This isn't a patient to start on sildenafil and say, we'll see you later. Okay. So this is where lower intermediate risk versus high risk is important. It's because those high risk patients need prostacyclins, they need continuously infused therapies soon. There are 3 treatment pathways outside of calcium channel blockers for patients. We start these conversations early. If this isn't one drug, this is a multi-drug step, and we're going to walk through them. They're expensive, they have lots of side effects, but patients can do really well on them, and we hold their hands as much as we can. Do you want me to step through treatments? So then I felt it alpha. Everyone wants to talk about Viagra and Cialis. Then they come to us and say, why is my ED not fixed? And we tell them they have schizophrenia. So it's always appropriate, once again, to refer to a treatment or a pulmonary hypertension center specialized in PH. For diagnostic dilemmas, maybe somebody who got started on therapy, you're pretty confident and they're not doing well. And the question is this disease progression, or is this they're not on the right therapies? Anything side effects, hospitalizations, and transplant. So we have a transplant program at the University of Utah, but it is time for transplant when patients are failing, when that RV is toast. We want to start those workups before they get to that point where they need that transplant. There is a lot of testing, there's a lot of commitment having to move to a transplant center. It's the same for the transplant. Okay, true or false? Better get this right. Every form of PH is clinically significant. That is absolutely true because every form of PH is associated with increased risk of mortality, side effects, and loss of life function. So we're in the state of Nevada. I hear you can gamble here. If you're gambling people, you always have to think about pulmonary hypertension. What are the odds that this is left heart disease? And most of the time, if this is what you're choosing, you're going to be right. So we look at the average American with lots of birthdays, diabetes, hypertension, obesity, metabolic syndrome, coronary disease, maybe atrial fibrillation, and then we look at those echo changes. If the right side looks pretty good, your chances are lowered. Are you familiar with this H2 HFpEF probability? Awesome. So this is those same factors, just put in a scale. Total points, and here's your probability of HFpEF. If you've got AFib, you're already halfway there. And then birthdays, so greater than 60, BMI of over 30. We use this a lot to help our patients direct therapy. So here's your next true or false. An electronically reported wedge has a mean of less than or equal to 15 is consistent with PH. That answer is false. This is one of our best patient examples. This is a reported mean of 15. You can see that wedge goes from 0 to 25. So end expiration. Stiff left atrial syndrome is another example. And please don't ever tell a patient that we can't treat group 2 pulmonary hypertension. We have to have this conversation often that we use diuretics, spironolactone being one of them. We can have that conversation later. Treat underlying comorbidities. Anything that we can do to help those patients get better. And then, of course, I hate it when exercise is the answer, but rehab. Rehab can help improve patients' quality of life. The biggest question here is why do we not treat with vasodilators? They harm patients. Okay, maybe they do nothing, but maybe they actually hurt people. And so riociguat, sildenafil, and macitentan have actually been contraindicated in some forms of pulmonary hypertension. Group 3 has to do with lung disease. I'm happy to have a PFT tutorial if you like. PFTs are, we look at them based on age, height, and gender, and that's how we decide what predicted numbers are. Why this becomes important is because if somebody has abnormal PFTs, that leads us down a different track with pulmonary hypertension versus if they have abnormal PFTs and how abnormal they are. So I'm going to jump through these. We can talk about reading PFTs later if you would like, and why we do them. But this is a picture of a gentleman who came to us with pulmonary hypertension, and he had normal PFTs, an isolated reduction in his diffusion capacity. Diffusion is how well oxygen gets through the lungs and onto the blood cell. And so with that being reduced, this is a good reason to think, wait, maybe this is a heart problem, maybe this is a lung problem. Lungs are not the only reason to have a decreased DLCO. Okay? So we actually sent him for a CT scan, and he has horrible interstitial lung disease, although on his PFTs it doesn't really show. So pictures and PFTs matter when you're trying to figure out a patient with pulmonary hypertension. Sleep apnea is huge. This is a conversation. Nobody likes to talk about it. Nobody likes their mask, except for the few people who would marry their mask if they could. But cardiac electrical remodeling of the ventricles and the atrium are just chronic effects of untreated obstructive sleep apnea. So it's hugely prevalent within our cardiopulmonary population. And obesity hyperventilation syndrome. Who here has ever seen a patient with obesity hyperventilation syndrome? Do you know what that is? Okay, can't breathe good, right? So about less than 1% of the US population has this condition, but probably 30% or more of our patients who are hospitalized with BMIs of 35 or more. The reason this is important, there have been some trials where patients have been started on positive airway pressure, so PAP of some form, BiPAP, CPAP, and actually had normalized hemodynamics. Having pulmonary hypertension, starting therapy, no longer have pulmonary hypertension. So have a conversation. Just because someone says I sleep well doesn't mean that they don't have sleep apnea. You probably notice in the atrial fibrillation lung as well. Here's just one more example of respiratory variation in obesity, where you're underfilled, overfilled, underfilled, overfilled. It cannot feel good. This patient had a BMI of about 55. So when it comes to decision making of do you treat, do you not, with lung disease, it really has to do with how much the extent of the lung disease and the severity of the pulmonary hypertension. The general rule is about a mean PA about 35 or greater, and very little abnormality on PFTs and imaging together suggests that maybe we could treat with pH or with pH therapies, but otherwise, once again, don't treat. This is just a question about a gentleman that had COPD, and there's a spoiler alert. He had a mean PA of 35 or 33 with an elevated PVR. He was doing really poorly, really active guy. He started him on sildenafil, and he also really tanked. Stats tanked, energy tanked, stopped drug. He thankfully recovered, sort of back to his baseline. But core pulmonary can look a lot like PAH on a heart cath. And then why don't we treat with vasodilators? Studies have been stopped. People have been hospitalized and increased mortality with pulmonary vasodilators and ILD, and primarily ILD. COPD, we're still out. We still don't treat, but studies have found both ways. Oxygen is the most potent vasodilator we have. If a patient needs oxygen, a patient needs oxygen, a patient needs oxygen. Those stats are less than 90%, mostly. We need oxygen. So refer to pulmonary, get a diagnosis, optimize. That's how we treat chronic lung disease-related pulmonary hypertension, treat sleep apnea, weight management, once again, offer rehab, and then send to an expert facility. This is really I'm just gonna spend a couple minutes on CTEPH. You guys see any CTEPH patients? Chronic thromboembolic pulmonary hypertension, old blood clots. So about 25% of CTEPH patients don't have a history of blood clots. So no DVTs, no PEs. Maybe even lower in Japan. There are no current screening recommendations after somebody has an acute PE, but if somebody's still short of breath, they deserve a ventilation perfusion scan. And the reason for a VQ over a CTPA, I'll show you in just a second, but 3 months of adequate anticoagulation is required to make a formal diagnosis of CTEPH. Caution with DOACs in people with a BMI of over 40 and hypercoagulable disorders, so factor 5, APS. Those patients need to be on warfarin. We do not use filters, and then these patients stay on lifelong anticoagulation. Who's seen a ventilation perfusion scan? All right. I apologize, his name was all over the matching slide, so I had to cut this picture out. For those of you who can see, this is a picture of his lungs, his ventilation. So a VQ scan is sort of like a hand and a glove, or two hands together. We look at where airflow goes and we look at where blood flow goes and try to match those up together. There should be blood everywhere there's air on this scan. For this gentleman who has CTEPH, he has perfect ventilation, perfect airflow. And then he has all these little holes in his lungs like mothballs ate them, where the blood flow should be. He had surgery, he's doing much better, but a CTPA said no PE. This is another person's VQ scan with an overlay of a CTPA with dual energy, which hopefully will be a new modality where we can skip the VQ and the CT and put it together. But you can see where it's red there's good perfusion, whereas black, there's nothing. So this is pretty significant disease. You can imagine those lungs look pretty good when we look at a CT scan, but then you try to see where that blood flow goes, and it doesn't. So CTEP surgery is a pulmonary thromboendorectomy, also called a PTE, or every now and then a PEA, but that can be confusing. So a PTE is a sternotomy. It's quite a surgery. I'll show you a picture in a second, but it essentially removes the clot out of the lung. Not all patients with CTEP can have surgery, but surgery is the best therapy for those who can. 2/3 of these patients will not have pulmonary hypertension anymore. Of course, a third will, but still 2/3 don't have to risk that organ failure and death. This is one of Dr. Selzman's surgeries from last year. So it's a gentleman with emphysema who had a lot of right lower lobe obstruction, and that's the lesions that were taken out of him. And this is before. This area of blue is lower blood flow, so blue to red. And you can see that he's got this beautiful perfusion 3 months after surgery. And this is a lady who presented to us. We diuresed her about 40 pounds, did a CT scan in the hospital. This looks like chronic PE. She was convinced that her holistic doctor was going to fix her pulmonary embolisms, but she agreed to be on warfarin for 3 months and come back. We told her if her blood clots were gone, we'd write an article about her. They were not. She agreed to surgery with Dr. Selzman. PE pressure was 77, down to 26 the day after surgery. Cardiac output actually improved. And what's really kind of fun about her, and I apologize, these are still images, is that her heart actually got smaller, speaking of recovery. So it's really hard to find a scan that the pictures look the same because her heart size was so much smaller. So here you can see this right side has very little flow to it, and that left side. She was on 6 liters of oxygen. She's no longer on oxygen. So don't miss CTEP. VQ scans are the only way that you can actually prove that there are not perfusion defects. The operable versus inoperable persistent debate will go on. Inoperable means you can't have surgery. Persistent means after surgery. We treat those patients with pulmonary vasodilators the same way that we treat PAH. So refer to a CTEP program. You can't rule out surgery unless somebody who can't do surgery rules out surgery. And then group 5, we're not going to talk about. And all pH matters. Any questions? We did it. And you get to have dinner. Yeah.
So when you're going back to your very first patient that you talked about, which is the snowboarder that passes out.
Yeah.
When you're thinking about that kind of patient, I mean, we tend to think rhythm disorder a lot of the times.
Yeah. So
when do you start thinking about pulmonary hypertension in that kind of a patient population? What ticks you off?
Echo.
Echo. Okay, so you're just looking for tricuspid reversion.
So this, he's in his early 30s and he went snowboarding with his kids and he passed out. And then let's sort of put the picture back of like, oh, I've been more short of breath over the last 6 months or so. He was in the hospital for 27 days. He got discharged and actually came down to us, but his heart was gigantic. He actually had an elevated wedge and a decreased EF, so they were treating him like a heart failure patient when really his pulmonary hypertension was so severe. So EF is normal. He's doing okay. We didn't cure him by any means because we can't.
One of the things I've heard about a lot is the 6-minute hall walk test or 6-minute walking test. How applicable is that? How do you guys do that? How do you have it accurately reproducible? It seems to be a lot of variation.
There is a lot of variation, which is why we tend to just tell our patients, even though you've done your 6-minute walk with your pulmonologist in Montana, we still want to see your 6-minute walk at our facility every year. Elevation matters, that corridor matters, how we do the test, whether patients got oxygen or not oxygen matters. It's really a where are you right now and where are you as we go in this treatment algorithm. So one way we sort of decide, oh, maybe a patient should have therapy, maybe not, is to try a therapy and see how they do. Do they improve that walk test? Do their symptoms improve? And then pull back. So like our COPD patient, his 6-minute walk test tanked. That was sort of our best, easy, cheap and easy objective measure of is this medicine doing anything.
Has it been tied to mortality or is that just all?
No, it's all quality of life. The first PH drug trials, all you had to do was improve a 6-minute walk test, and bada boom, bada bing, you were an effective therapy. Now we've got mortality data, we've got everything else that comes with that. But the 6-minute walk test was just that one way we could try to say, can somebody do more than they could do in the past? So literally you walk for 6 minutes.
Sorry, a patient with CTAP, possible CTAP, but not clinical, pulmonary embolism, as you said. You still try them on anticoagulation for 3 months?
Yes, so let's say that you see somebody who has webbing on a CT scan. You still need 3 months of adequate anticoagulation. The best example we have of this is we had a patient who was morbidly obese and they were on a DOAC, and we had this discussion with them saying you need to be on warfarin for 3 months. Their perfusion action parity didn't go to normal, but it improved over time. And we use UCSD a lot for our really distal disease patients that we know may or may not be candidates for surgery, and they can actually do balloon pulmonary angioplasty and open up some of those lesions. That's also in a select population.
That was my next question. Do you guys do that catheter-based thromboembolectomies?
Well, in acute setting, yes. In chronic setting, no. BPA was done in the US in the 90s and killed a lot of people. I shouldn't say a lot of people, but enough people that we sort of stopped experimenting with it. The Japanese perfected it. UCSD learned from the Japanese and brought it back to the US. So Craig Salzman does surgery. We don't do the BPA side of things and haven't really experimented there.
If we take these questions during dinner, would that be okay with everybody?
Yes.
Great, thank you, Dr. Khan. Thank you very much.
All the bad patients after that. I haven't had that. So you don't have.
I'll get you either.
Well, you guys are like a lot of motivation.
Will you guys share? That's our job.
Yeah.
Everybody has to stay, but yeah, it sounds like you guys are. We're gonna get back.
The vision itself and like do for the program.
Really?
Yeah, oh yeah.
Yeah, I come to Stacy and so we're trying to get a couple. Yeah.
Oh, really?
Yeah, it's not like the image of like to be that conversation.
Obviously, we're recording it all at the same time. Certainly would do that first.
Sometimes it shrinks after diarrhea.
It only comes down, but it might still
Yeah. An MR moderate and the LV how are you? That was my I always bring a
probably more than advanced failure paths. They have some.
Get homework. What can we not do?
Now they're word. Oh, that's a much better. Water or Coke or something?
That's cardiomyopathy patients. How do I get them? The guy the other day who he said, I've got so it's like 9 some years, but it's so his excellent. He said, I'm compression cardiomyopathy. So there's no people or anything like that. So I said, you should study. He's 9 some years. But he'd be somebody. Yeah. Yeah, I'm going to finish that. Which university? We're not. I was sitting for him. When they get bad.
I do this all the time.
Yeah.
Better is better.
That's what I want to do. So I'm making this also. See, look, it's not little. It's not when you're at the end of your. It's early, so I'm moving. You're not going to do it. As soon as you set a whole bunch of people, you burn them over. Japanese guy.
A lot the same way when the cardiologist is
You do it. Thank you for That's a lot, huh?
a lot of this. You know what I
How many?
all over the United States, all over the world. One patient.
What's your
Visiting hours are now over. Visiting hours.
Tatiana, beautiful name.
I'm tired. I
A beautiful hospital here.
Better the fellow, surgeon, who was so the job for him, he applied
Load it up.
correct condition. Big surgery, he was Mr. West Virginia with his brother. Bombs out. It was just ordinary cases. They're interviewed and he called me up for the program. And I said, listen, I'm in these Reno. He'll operate on everything. Reno, nice guys. Everything's south of Reno's out. Whether it's Dayton, Carson, Barnaville, Lake Tahoe, you know. It's too much.
Yeah, like you said, how many people? 6,000 is Carson, but the whole area?
300,000.
Yeah, no problem. Good luck with everything. Nice meeting you. Take care.
I was mostly very happy for your program. Are you guys planning to start a program?
I am. Let's go get some more chicken. Stay up there? Oh, okay, great.
Nobody in Reno. Second metro. Don't put the staff oh, you got it. You can't get him in. They're executive. You can't really. go there and love it.
Yeah, it's cheaper.
Cheaper.
You live around.
Yeah. I feel the question's going to be, when do we feel when they got a bifusion device there, and all what's the hardest thing getting better. And you have to, LB says, they got some requirement, just get them in. So get them in, follow.
Or hair of the rudder.
Right. See, once that's all. But when you need
They're
it,
not aggressive. We're not going to push it when they're not ready. But having them helps a lot because
a familiar guys, but no one. Three. Brother. He's got a pacemaker. He's got to be fit. So I've got brother. There's no one. They're ready. I can centimeters, but I'll put on his. Okay, we got to hold it now. You should have looked at him. Wow. He said, 3 years ago I did meth, and I think it's like, meth is doing this. Of course it didn't help, but
left in the front of the table. January. We always how we get 600. With it's dry, so you don't. So that's why it's so you guys are welcome, and if anybody's interested, Angela, Camila, we will get you. My cell phone, my email, just great guy. Yeah. Carmela came for us supposed to be.
That was your mom earlier.
The agenda and everything. Let me go get I'll bring it back.
Anyone? I was going to give you a PFT tutorial if you would like me to do that. What does PFTs actually mean?
Please.
Okay. Can I go back to presentation? Anybody in power? Do you guys order PFTs on your patients very routinely? And do you get the numbers, or do you just get a report that says obstructive lung disease, restrictive lung disease? You get both. Awesome. Okay. So when it comes to breathing tests, we look at how tall a person is, how old they are, and what gender they are. Puberty, and it's all downhill from there. So we lose lung function every year. That's why predicted numbers are important. So you can look at a patient who has had a lot of volume loss, but it's been 10 years and it's perfectly normal. So that's why we've got to look at predicted numbers over time. And then as we get older, we also get more obstructed naturally. So a number of 70 in somebody who is 80 years old is actually very normal compared to 70% in somebody who is 30. And what I'm talking about is a ratio of how much air you breathe in and how much air you get out. So when we talk about obstructive lung disease, we're going to talk about a 70% ratio, and that's the goal initiative.
You would see that.
Somewhere probably in like the 40s. Perfect, right there. Okay, so here's a set of normal PFTs for a patient. So the first thing we're going to look at is what is their, so there's two ways to read these. There's the Jennalyn way to read them and talk to a patient, and there's the ATS recommendation of how to read PFTs. So I'm going to tell you how I walk through this with patients because we're looking at their actual PFTs. So this looks really, really busy, but there's three numbers that you really need to look at. First number being FVC, which stands for forced vital capacity. That is essentially a number of, when I take a big deep breath in, how much air can I get in? Okay, so these are functional measures. These aren't total lung volumes. 80% is an A. So if a patient's 81%, that's normal. So 100% is the predicted number. 20% on either side is that bell curve, totally normal. 80% is an A. So this person has 85% predicted volume, okay? Now, we make them force their air out in 1 second with the PFT, so they take this big deep breath in and they blow out as hard as they possibly can, and they have to do it the same 3 times in a row. PFTs can be really hard on patients, but we want that consistency. So FEV1 is forced expiratory volume in 1 second. You obviously you can't get out more than you can get in, so we put that on a ratio. We want somebody to get at least 70% of that total air volume in, out in 1 second, and that's this ratio, FEV1, FVC. Okay. And that's where we make that distinction. Does someone have obstructive lung disease or not? And that's the first step to start when we're actually interpreting what a PFT means. In our PFT lab, we instruct all of our patients to get 4+ of albuterol. That is the standard for reversibility testing. So we have reversibility in pH and we have reversibility in asthma and breathing test. And we're looking to see if that amount of air out in 1 second improves. This person does not improve. If it improves by 12% or more, you potentially have asthma, depending what your other numbers are. So first step, FVC, FEV1, look at the ratio. The next set of PFTs is somebody who has restrictive lung disease, so interstitial lung disease, pulmonary fibrosis, obesity, which is probably our leading cause of restrictive PFT in our PFT lab anyway, kyphosis, so cute little old ladies that start to bend over. They don't have as much room in their chest anymore either, or drug reactions, amiodarone. This is what you're looking at. You're looking at your FVC. So to start reading PFTs, you look at the ratio. This person is normal. She's a 75-year-old woman. Ratio is normal. So the next thing we look at is her forced vital capacity. How much air can she get into her lungs? She gets 35% of predicted. So she, by definition, has restrictive lung disease. Hers is from, she's post-ARDS, or ARDS. And then this is a gentleman with obstructive lung disease. And the way we know this is obstructive is because we look at his ratio first. His ratio is 51%. So you answer your question. Obstructive, not obstructive. He is obstructive. The next place we actually go for him is going to be his FEV1. So his FVC is normal in this case, but the next most important number is how well he gets air out, because this is how we stage his disease. And this is his PFTs 3 years later. Disease is more severe. So you can see here his FVC was normal at 4.63 liters. 3 years later, his FVC is now reduced at 2.79 liters. He doesn't have interstitial lung disease. He does not have a restrictive lung disease. His obstructive lung disease is horrible. Okay, so he now has so much air left in his chest that he can't get any more air in. Okay, so going back here, we look at his FEV1 here, and it's 63% of predicted. That's considered moderate obstructive lung disease. So once again, you look at here's ratio, FEV1, FVC, it's low. How bad is his obstruction? You look at his FEV1. And these are flow loops. Patients with COPD can breathe out for a really, really long time because it takes them so long to get that breath out. Here, once again, he has a swooping, which is an obstructive lung disease pattern. I don't think I put a restrictive patient on there. But this is fairly normal. That's just got a little bit of a curve. So 3 years later, his obstructive lung disease is horrible. His FEV1 is 1.62, so he's now in a severe category of COPD, even though his FVC has fallen a ton. And he doesn't meet any of these marks about how quickly he can forcefully exhale because he has so much air left in his side. This is the guy who went on to end it. He ends up having, that's not him, sorry. He ends up with an EF of 21% because of his poor pulmonary. Any questions? How about diffusion capacities? Diffusion capacity is on that same scale, 80% of predicted is normal, and it tells us how well oxygen is actually getting through the lungs onto the blood. If that number is reduced, it can be heart or lungs, or both, or one or the other. So by that I mean heart failure versus interstitial lung disease versus emphysema. And we will have patients who have pretty severe emphysema that have totally normal PFTs. So once again, PFTs and imaging, you got to put it together, especially in PH.